YS is a 32-year-old man presenting to the emergency room with fever, dysuria, and purulent urethral discharge. He tells the admitting nurse that he had an intense pain between his legs due to an ulcer on the shaft near the head, and that all of this came just a few days after meeting and intimately interacting with a woman, different than the woman who he lived with and he normally interacted with. The medical team asked some more questions, and they found out that that woman he lived with was HIV positive. At admission, a blood test reveals that YS has an HIV viral load of more than 10 million copies per mil, and his CD4 count was 400, normal range between 500 to 1500. This is sufficient to make a diagnosis of acute HIV infection, but more was happening. High-risk behavior with penile ulcer and urethral discharge mean co-infection with another sexually transmitted disease, but which one or ones? Testing returned negative for gonorrhea and chlamydia. The urethritis was thus non-gonococcal. Based on his presentation and on treponema-specific antibody test, YS was found to have primary syphilis. Intimate human contact involves significant exchange of microbes. Ones that aren't part of normal human microflora can cause significant disease, one of them being Treponema pallidum, the bacteria responsible for syphilis. What YS has been exchanged person to person for thousands of years, but most well documented on paper starting 500 years ago. In 1494, King Charles VIII of France took French troops and mercenaries to Italy. He was offered the kingdom of Naples by the Pope because the King of Naples refused to pay feudal dues to the Pope, and King Charles's grandmother was from the previous ruling family of Naples. The King of Naples and the Pope had reconciled before the Pope died, but then the King of Naples died too, and an ensuing succession crisis led to Charles's invasion. Armed conflicts impose ravages, and this was no different. King Charles's army camp started to notice that their men were getting an illness that would cause them to become disfigured. Doctors hadn't seen an illness like this before, but it was spreading. When his army returned to France, this strange illness followed them home, and this disease spread all over. The age of syphilis had arrived in Western Europe. And this historical context is important because the general course of illness hasn't really changed in the last 500 years. There's an initial infection that appears a few weeks after contact that's usually visible in men and can be hard to visualize in women due to differences in physiology, and it may or may not be painful in both. There's a latent phase that then becomes much more severe as an illness encompassing multiple organ systems later. And without treatment, this will cause permanent damage all over the body. So when we say disfiguring illness, what are we talking about exactly? Well, during the contact when Treponema pallidum is acquired, microabrasions can develop at those points of contact. The bacteria enters and then creates a chancre. We have a pretty good idea of how these microabrasions happen. In the male case, it's going to be visible, but truth be told, anywhere that has contact with someone's lesion, especially mucosal contact, can initiate acquisition. The spiral-shaped bacteria has arrived. At first, it replicates slowly, but then it forms the lesion, and then it spreads throughout the entire body. At first, the immune system takes care of this. It produces antibodies, and the person appears to get better. The lesions start to go away. However, the problem is, for YS, his immune system is now compromised because at the same time of his syphilis diagnosis, he had acute HIV, with blood tests confirming that his immune system cannot operate at full function. All of this explains the lesion for YS on the shaft at the head. Other than the symptoms that he presented with, everything else seemed okay. If syphilis is caused by bacteria, then an antibiotic should be able to treat it. In the hospital, YS is given pen-G-benzathine injection, and he's given additional doxycycline antibiotic to be taken for 6 days upon discharge. They scheduled him to return to the clinic for follow-up so that they could confirm by blood test that his syphilis had been taken care of by the penicillin, but he never showed up. As the months passed, YS seemed to be okay, but around a year after getting that chancre, he started noticing severe upper abdominal pain on his left side. He was told to go to the emergency room to get treatment, but in his mind, they didn't fix him the first time. They clearly just want to make more money off of him and have him keep coming back, so he promptly declined. But a few more months at home and things didn't get any better. One morning, YS woke up and everything in his field of vision was blurry, knowing that the first emergency room that he went to obviously, in his mind, didn't do anything. He went to a different one where they gave him some antibiotic eye drops to try and help clear some things up, but they didn't help either. 2 weeks later, YS woke up and he couldn't see at all. Over the last 6 months, YS had severe bouts of nausea and vomiting. He'd feel abdominal cramps on his left side, and these would squeeze so hard. He'd huddle over in his chair. The pressure he'd get in his head from holding his breath to try to make himself feel better would end up making it feel like his eyes were getting pushed out of his skull. He'd grab his side, begging for it all to stop. But as the days passed, when he stopped eating, he didn't have as much to grab onto his side anymore because he had lost 40 pounds. He didn't want to eat, and he couldn't hold anything down. Back in the emergency room, again, doctors noticed that in addition to stomach pain, YS had lesions on his scalp, and he had been losing hair. A blood test finds that the HIV viral load had decreased to 40,000 copies per mil, but that his CD4 T cell count was 244. Ophthalmologic exam finds that his right eye was 20/400 and his left eye could only perceive light. CT scan of his head didn't reveal anything, but when they analyzed his cerebrospinal fluid, they found low glucose, high protein, and high nucleated cells. It was negative for treponema. This doesn't necessarily mean that he doesn't have neurosyphilis. The test is not 100% sensitive, so he might actually have something happening, but they need to look deeper to know for sure. But what the medical team does know for sure is that YS has nodules and ulcers in his GI tract because esophagogastroduodenoscopy revealed them. Biopsy of his lesions found inflammation, neutrophils, and granulation tissue. Immunohistochemistry didn't find Helicobacter pylori, meaning that these weren't peptic ulcers that you normally find. Rather, the stains found spirochetes consistent with treponema pallidum, meaning that he has syphilitic ulcers in his stomach, causing his abdominal pain, his nausea, vomiting, reluctance to eat, ending with 40-pound weight loss over the last 4 months. The syphilis had spread to his eyes and to his stomach. Didn't his body cure the chancre when he was first infected? Why is syphilis in parts of his body distant from the original lesion? The immune system response to treponema pallidum is a paradox. On the one hand, the immune system handles the original chancre and the patient appears to improve. But during this time of improvement, the bacteria is replicating and spreading all throughout the body. This first wave of illness is called primary syphilis, but a second wave can appear as secondary syphilis, where acute manifestations can reappear and then sometimes disappear. In some cases, primary syphilis isn't even noticed by some patients because the symptoms aren't painful. And chancres often aren't painful. And sometimes, if or when they get noticed by the patient, no treatment is sought because it doesn't hurt. It just looks a little weird. And this could increase the chances of transmission to others because the patient may not really realize what's happening to them. And reemergence of symptoms following a latent phase could then make the severity of disease worse. And this is assuming that the patient is immunocompetent. But given that YS had a diagnosis of acute HIV several months ago when he first presented to the emergency room, and that his CD4 count was still low, he's likely to have more severe disease. YS was considered to have gastric syphilis, and with ophthalmologic involvement and CSF markers, he was also diagnosed with neurosyphilis. This warrants pengbenzethine treatment for 14 days every 4 hours with concomitant antiretroviral therapy for his worsening HIV infection, all during hospitalization. Gastric and neurologic involvement of syphilis is disseminated, but the medical team had obtained a gastric biopsy. They also got one from his colon. When they further examined these, they were able to sequence the DNA of the treponema pallidum, and it was here where they found that something was wrong. Typically, when we see someone infected with syphilis, and if we're able to get a chance to sequence the genome of the bacteria that's infecting that person, the sample will usually just have one particular strain of treponema. That's the one that infected them. That's the one that's growing and spreading in their body. There's decent records of treponema strains where certain geographic locations will have trends. One strain is found more in one continent than the other. And this makes sense because of this particular organism and how it's spread amongst humans. The problem with YS's sample is that the medical team found 2 different strains of treponema, meaning that he has a co-infection with 2 distinctly different kinds of syphilis. It's unclear if he was somehow infected twice, so we would say that he acquired both sequentially, or if they were co-transmitted, meaning that the person that he got it from also had both of these together. One thing about treponema is that it can't be grown in a petri dish. It dies without the proper nutrients of which is found when it lives inside a human. So sometimes you might find people that will try to categorize treponema as a parasite, but really, it's still a bacteria. And this is why it's very hard to detect directly. You need the antibody tests. One thing that highlights this difficulty is how treponema pallidum is studied. The first time the actual bacteria was described, despite this infection being known since at least the 1490s, was when in 1905, German scientists were the first to find the spiral-shaped bacteria from the cerebrospinal fluid of a patient. 7 years later, American physicians working for the government were able to isolate and keep one particular strain of treponema pallidum by doing this. They took the CSF of a neurosyphilis patient and injected it into a rabbit. At least since 1906, scientists had known that rabbits and hares could get similar infections that humans would. Knowing that the human patient's CSF had treponema in it because he was infected and had neurosyphilis symptoms, they transferred the bacteria to rabbit testes to replicate the bacteria. If it won't grow in a dish, grow it in a living being. One of the doctors who did this was named Nichols, and so thus the syphilis that was replicated in that rabbit was known as the Nichols strain, which is still one of the predominant known strains today 120 years later, but it's a little different now. One sample was taken from YS's colon. There, they almost found exclusively what they thought was the Nichols clade of treponema, but something was wrong. In 1977, more than 70 years after Dr. Nichols and Dr. Huff had isolated the Nichols strain, staff members from the Centers for Disease Control in Atlanta isolated another strain of treponema pallidum that they would call street strain 14 or SS14. By this time, the Nichols strain was the oldest available strain that was isolated within a few years of identifying treponema as the causative agent for syphilis. Nichols had been the most widely studied strain. When bacteria infects another species of animal, you can expect that it's going to mutate. Back in 1913, they weren't able to sequence DNA. Actually, they didn't even know double helix structure back then. But in 1956, a study was done where human volunteers were purposefully infected in a lab with Nichols strain treponema pallidum, and it was confirmed moving it to rabbits didn't impact its infectivity in humans. This kind of study is unethical. It did tell scientists at the time that the Nichols strain was still relevant for study, but even more unethical is not communicating the purpose of a study to humans and then denying them treatment in the name of documenting the natural history of a disease. And this was known to have happened with the Tuskegee syphilis study, and patients weren't told that they had syphilis. Another experiment happened in Guatemala where they were deliberately infected with syphilis, and the effects of these kinds of studies being so unethical, they still linger today, where there's limited trust in some clinical trials. You can't blame people for not trusting this when this happened. I did talk about another clinical trial problem similar to this in an episode of this podcast before. There's some paid organizations that want to reform how certain trials are done. But don't forget, those reforms will always create a different set of problems because you're dealing with people, and people are infinitely complex. Having a second reference strain from a strain that has some significant differences could be important to keep track of how things continue to change over time. And the problem for YS was that when the medical team did the sequencing, they found exact genes that were associated not only with the Nichols strain, but also SS14. Usually, when someone is infected, they just have that one strain of treponema, but YS had two. So either he was infected more than once, or he got infected with both strains at the same time. It's not to say that this hasn't happened before, but this hasn't been documented or seen before. Interestingly, in Seattle, where YS was, the SS14 clade treponema was known to be collected from heterosexual patients at that time during the years of 2021 to 2022, when he was most likely infected. But the Nichols clade during that same time, in the same area, had only been collected from men who had male partners, despite YS's history only mentioning female partners. In 1998, 85 years after the Nichols strain was isolated, the entire treponema genome was sequenced from that strain. Scientists had developed the techniques to do it without sacrificing countless rabbits, though they had to sacrifice some for this particular study. In the genome, they discovered why treponema pallidum couldn't be easily cultured, because it can't make a lot of its own nutrients. They found that it has similarities with the bacteria that causes Lyme disease. they were able to get an idea of why it could evade the immune system for so long following the first immune response. And they were able to find out how and where penicillin would bind to destroy it. YS's colon mostly had nickel strain, but the scientists noticed something. A protein that probably transports fatty acids is encoded by the gene TP0865. When they looked further, they identified variants. Parts of the TP0865 gene that's associated with the nickel strain were found mixed with other parts of the SS14 strain. Some parts of the gene also had substitutions in the amino acid sequence. In the stomach sample, another gene called TP0705, which encodes for MRCA, a penicillin-binding protein, was identified. Transfer from the nickel strain was found in the SS14 strain, with a new mutation never before seen at amino acid 478, where a methionine was present instead of a valine. The DNA found here indicates that part of the nickel's DNA was now in SS14 in YS's stomach. Multiple other genes, of which their sequence is up to date in the region, were found to be recombined in YS's stomach sample. All of this meaning that for the two strains of treponema inside his body, it appears that they may have been mixing their DNA together, creating a recombinant treponema pallidum. In the last several decades, scientists have been documenting how this bacteria and its various strains have been changing over time. At the population level, the bacteria was known to mutate very slowly, with one nucleotide change every 3 to 7 years. However, the number of syphilis cases has been increasing rapidly over the last 10 years in the United States. And despite YS's case being the first documented co-infection with DNA recombining occurring between both strains, it could mean that treponema pallidum might be on track to change at a different rate now. Street strain 14 was sequenced in the first place because doctors started noticing that syphilis was becoming resistant to antibiotics. The issue was the kind of antibiotic being used. Back then, macrolides were used to treat the disease. These medicines inhibit bacterial protein synthesis by binding to the 50S ribosomal subunit. These medicines come in tablets, and they're convenient for patients to take when they're not in the hospital because Pen-G needs to be injected. The problem is, all syphilis is resistant to macrolides now. However, despite being used for decades, treponema pallidum has not developed resistance to penicillin yet. And the V478 mutation found in YS's body didn't appear to be clinically significant. There was no evidence that it conferred penicillin resistance in the individuals who had it. However, it might only be a matter of time before a mutation does appear that does enable that resistance. It has happened with macrolides. The one thought that I had about this particular paper is that when you look at CDC county-level syphilis data, you'll notice that Seattle, or King County, doesn't really have that high of a primary and secondary syphilis rate in women, done this way as to be able to tie it to congenital syphilis. It's 22.5 per 100,000 people. If you look at neighboring Snohomish County, it's less than half at 9.4. Seattle-King County's rate is hardly the highest in the country. You can find other metro areas smaller than Seattle, like Cleveland-Cuyahoga County, that has 19.8. Atlanta's Fulton County has 23.4. St. Louis City has 66.7, but St. Louis County has 19.9. If you want to see something that we definitely don't hear about every day, it's that places in South Dakota have rates of more than 2,500, more than 100 times that of Seattle, happening on Native American reservations. And it's not just one county, it's very many parts of the state. Actually, parts of the region spanning into Montana and North Dakota too. Now, these places might actually have less cases simply because there's less people here than in a place like King County. Perhaps New York's rate is only 6.5 because it has more than 10 times more people than Seattle. So, by a pure number standpoint, there are more cases in New York despite a lower percentage or incidence rate. When we're thinking of mutation and recombination and things that have only been documented to be happening for the first time now, we have to remember that if we can see it happening now, it's likely that it has happened before and is happening in many places now all around the world. There's an estimated 8 million people who got syphilis around the world in 2022. There's probably more than that, because think about this. The nature of the disease may be perceived by the person to be embarrassing, or they just don't want to deal with judgmental people and having that attitude. This will make it harder for them to want to seek treatment. Even YS kept leaving the hospital against medical advice and would tell the new emergency room that the sore on his leg was because of a spider bite, not because it was syphilis. While the history had noted a few points about what had been going down, there's no way for any person on the medical team to confirm absolutely YS's history. And if he doesn't want to divulge that information, then he doesn't. The final point about this is that in the United States, there's been a shortage of PenG. It's actually been ongoing for many years now. We've actually been having nonstop rolling drug shortages since at least 2010. Currently, PenG in the United States is solely licensed to the largest company in the space. And there's no generic versus brand issue here. It's just one brand. PenG isn't a tablet, it's an injection. The sheer volume of liquid that gets injected into a patient with syphilis can kind of be shocking the first time you see it. And this injection is painful, it's daunting, it's deep into the muscle, and it's in a place that feels really weird. And I don't know how the events of 2025 are going to disturb the supply chain, but in 2024, the FDA did take some measures to try to alleviate some supply chain issues, especially when cases have been increasing. But what's going to happen to surveillance and testing programs? Good question. So the few things that we do know are this. First, syphilis cases have been increasing in America. They're increasing in other countries too, on a trend that started pre-pandemic. The second is that the bacteria that causes syphilis has been changing. It's radically different now than when we started documenting it in the late 1400s. It appears it was much more severe back then versus now. We've really only known about Treponema pallidum since 1906, and we've known the whole genome since 1998. However, in these ensuing almost 30 years, we know that this bacteria can change on its own. Random mutations intrastrain were found in YS, but now we know that inter-strain recombination is possible in the setting of co-infection. High case burden now versus before means that the likelihood of multi-strain infection is increased, and that people may be creating new strains of Treponema pallidum that will behave in ways unknown to us now. This can change its virulence, it can change transmission patterns, it can change the symptoms that can develop, especially when HIV is involved, and it can deeply impact how it's treated if a mutation that confers penicillin resistance emerges. There's going to be people who are going to dunk on the folks who get this, but you have to remember, many times the initial infection is asymptomatic. Especially in women, they might not even know that they have it because a painless chancre might be growing inside their body, not easily visible. And the tough part will be the infection getting passed onto the children, given that the mother may not even realize that she was infected. So, this is how syphilis is mutating in Seattle. Yes, it's probably mutating and happening like this in ways that we don't even know about yet all around the world simultaneously. However, it was documented here first during a time of rapidly increasing infections. Thanks so much for watching. Take care of yourself and be well.